Hello, I am Dr. Lawrence Smith, Dean of the Donald and Barbara Zucker School of Medicine at Hofstra, Northwell. Thank you for tuning in to Well Said. In a culture of community, scholarship, and innovation, the Zucker School of Medicine is dedicated to transforming students into doctors who will improve healthcare, inspire change, and better the lives of the people they serve. It is why we are pleased to collaborate with WRHU Radio Hofstra University to bring you a program committed to sharing expert discussion and insight on health and wellness topics important to you. Join us today and each week for a recommended dose of Well Said with your host, Dr. Ira Nash.
Hello, I'm Dr. Ira Nash. Welcome to Well Said. Continuing our recent conversation about dermatology, today we'll be discussing eczema, one of the most common causes of itchy skin. My guest is my colleague, Dr. Sheila Shaigany. Dr. Shaigany is the co-director of the Inpatient Dermatology Consultation Service at Northwell Health and is an assistant professor of dermatology at the Zucker School of Medicine, and I'm delighted she's here with us today. Sheila, welcome to Well Said.
Thank you so much. Thank you for having me.
It's become my habit to ask all my guests the same first question, which is, how have you been holding up through the rigors of the pandemic?
It does feel a bit like a marathon, but I'm just grateful to be busy. And it seems like things are, lightening up. So, at least infections seem milder. So I think there's light at the end of the tunnel.
Yeah, I would have to agree with you, although it does raise the specter of the old joke that the light at the end of the tunnel is the headlight of the oncoming train, but
Right.
We won't go there.
Right.
So let's talk about eczema. But before we do that, I think it would probably be helpful for our future conversation to have you start by just describing briefly the normal structure of the skin.
When we talk about skin, you can think of it as really three layers. There's a very top layer that is a very thin layer. It's called the epidermis, but that's where a lot of the action sits, and that's what provides the barrier for our skin. But it's a very thin layer, less than a millimeter in thickness on most parts of the body. And then underneath that, we have the dermis, which is primarily composed of collagen, but it's also vascularized. So we have blood vessels and other appendages such as sweat glands and hair follicles, and the function of the dermis is to support the epidermis and provide nutrition for the dividing cells in the epidermis. And then finally, underneath the dermis is a layer we call the subcutaneous fat, basically the fatty tissue. And that's a metabolically active layer that helps insulate the body and provides cushioning for some of the deeper tissues, such as the muscles and the visceral organs. So altogether, the subcutaneous fat at the bottom, followed by the dermis on top, and the epidermis at the very top are what we mean when we talk about the skin.
That's a really solid foundation for some of the things yet to come. I want to pick up on something you said about the skin being a barrier. So it's more than just sort of cosmetic covering for all of our muscles and other organs, right? So the skin functions as an organ itself. Is that correct?
Absolutely. And it really does, calling it a barrier is it's a barrier in so many different ways. It not only protects us from, this inhospitable environment that surrounds us on a daily basis. So it not only functions as a physical barrier and prevents just things from entering in, but it also is a barrier against UV light, which can be carcinogenic. So a certain type of cell, melanocytes, help absorb that energy. It also serves as an immunologic barrier. We have specialized immune cells in the dermis that help from an immunologic perspective. So it's a barrier in so many senses of the word, but it does so many other things too. It helps regulate temperature through actions of the blood vessels and the sweat glands in the dermis. All of our sensory nerves are contained within the skin, so the skin helps us sense cold and hot temperatures, light touch, sharp touch. We even have specialized touch receptor cells in our epidermis, the top layer, that are what allow us to do things like use an iPhone. So many different important. That's very important. That's probably number one. I should have led with that.
No, but I guess what you're describing is really our skin is in many ways how we interact with the world. I mean, we see, we hear, a lot of other things are mediated through the skin.
Exactly, exactly. And especially with the case of eczema, often the world's first introduction to our body is through the skin.
Yeah. So, so with that as a really solid background, what is eczema?
So, eczema is really a wastebasket term. It's a very general term that's almost synonymous with the word dermatitis. Now, as dermatologists, when we use the term eczema, we use it to broadly describe a group of rashes that have a similar pattern of inflammation under the microscope. So all eczema under the microscope demonstrates a term we call spongiosis, which essentially means that there's a lot of edema or swelling in between the keratinocytes, which are the cells in the epidermis. And that's what eczema means. Now, a lot of people will use eczema and the term atopic dermatitis interchangeably. And even as dermatologists, we sometimes do this just when we're talking to our patients when they have atopic dermatitis. But they really are very different terms, or not very different, but rather atopic dermatitis is a more specific condition and is just one of the many types of eczema.
Okay. Dermatitis, I'm taking, is just a general term that means inflammation or irritation of the skin. Is that right?
Yeah, it's like an inflammatory rash that tends to have like an eczematous appearance, eczema-like.
Okay.
Yeah.
You said they all look alike under the microscope. I assume what you mean by that is if you were to take a skin biopsy, take a piece of the skin out and slice it very thinly and look at it under the microscope, that's what you'd see.
Exactly. So it's very difficult to use a skin biopsy alone to distinguish from the different types of eczema. You can really only distinguish whether something is acute versus chronic, and it's really the clinical picture and overall history that helps guide our diagnosis when trying to determine what type of eczema we're dealing with.
For an individual, a patient who has this, they're not taking a look at their skin under a microscope. What does it feel like from the patient's perspective? What would they be experiencing?
So most types of eczema, including atopic dermatitis, which is one of the more common types of eczema, especially in children, is very itchy. So that's one hallmark feature to almost all types of eczema. It's very itchy. It tends to present with a similar look or morphology, the word we use in dermatology, where the rash is often scaly, so it's got like a white scale or almost like skin peeling off kind of look to it, and it's often red or inflamed. I'll talk a little bit about atopic dermatitis specifically. That atopic dermatitis is a chronic condition, and it's a relapsing dermatitis that almost always presents in childhood and usually before the age of 5. And we tend to see it coexist with other so-called atopic conditions such as seasonal allergies, food allergies, and asthma. And we also know that atopic dermatitis is frequently associated with certain genetic factors that contribute to an altered skin barrier and immune dysfunction. So in a child with atopic dermatitis, it's often a clinical diagnosis. We often see these scaly red plaques that like to go to the skin folds, the flexural surfaces. So very classic areas of involvement for atopic dermatitis are like the what we call the antecubital fossa, basically the other side of your elbow, or the popliteal fossa, that fold behind your knee. So those are really classic areas of involvement for atopic dermatitis. But we also see involvement of the hands and feet and of the hands, and there certainly are exceptions. For example, in infants, infants with atopic dermatitis tend to have their rash on the extensor surfaces. So rather than in the skin folds on the extensor surface of their arms and legs. And in darker skin types, we often see more of what we call like a papular rash, meaning little bumps rather than just broad plaques. And that is a term we call papular eczema, which is a type of atopic dermatitis, and that can also favor the extensor surfaces. So atopic dermatitis does have a little bit of variability in morphology, but the itch and the redness and the scale and the predilection for skin folds are some key features that maybe patients, and the presentation in childhood are key features that can be helpful for patients.
You know, you mentioned that the scales are white and the skin gets red. We did a show recently about the different kinds of presentation of common illnesses in people of different skin color or skin tone. And I wonder if you could address that with regard to this particular skin condition.
Yes, and I'm so glad you bring that up, because what's red on somebody with fair skin is not always so obvious in somebody with tan skin or darker skin. And so as dermatologists, we're trained to pick up on that. It can be subtle. Sometimes in somebody with darker skin, red can look a little bit more purple. And even chronic atopic dermatitis, regardless of skin type, but especially in darker skin types, can look a little more brown rather than red, or hyperpigmented, as we say. So there certainly can be variability in erythema, as we call it, depending on the skin type. And as dermatologists, that's what we study. We're trained to pick up on that, but it may not be so obvious if that's not what you've been studying for years.
Sure. You mentioned the association with things like asthma and allergic reactions. Is that connection understood? Is there some sort of underlying immune problem that causes this?
I think we understand part of it, at least. So we know there's a genetic component to at least some atopic dermatitis. For example, we see that it runs in families, and we've even identified certain mutations involving a protein called filaggrin, which is a key protein that's essential for the formation of the top layer of the barrier of the skin. And so we know that when the barrier is dysfunctional, whether it be from a filaggrin mutation or even just dry skin, certain antigens or allergens or anything from the outside environment can enter through the skin and elicit an immune response. And we see a very specific pattern of immune response that it's a type of T cell called a Th2 T cell, and these cells really get triggered in atopic dermatitis, and they, as we are learning through research, serve as an initial trigger for systemic allergies down the road, including food allergies and even asthma. So many view atopic dermatitis as an initial step in what's called the atopic march of atopic dermatitis, allergies, and asthma. Those same immune cells that get activated in the skin then go on systemically to react to inhaled allergens and so forth.
Well, that's really interesting. Are they related to other kinds of inflammatory conditions too? I'm thinking of like arthritis and that sort of thing.
The connection is not as strong, although we're learning more and more as more research comes out, especially with some of our big data sets. We're able to look at certain comorbidities, especially in our adult populations. Probably the most, one of the more common autoimmune diseases that we see coincide with atopic dermatitis is alopecia areata, which is an autoimmune type of hair loss, and so we do see a connection there. But the connection with autoimmune disease is as far as we can tell, not as strong as we see with other Th2-mediated processes such as asthma and systemic allergies.
Interesting. You mentioned hair loss. Are there other potential complications? I mean, it's bad enough to have an itchy rash, but are there other things that go along with this?
Well, itch is so itch is no joke. Itch is probably one of the symptoms, I would argue maybe even more than pain, that really significantly impacts quality of life. And we really see this in our children, where there is a significant impact on sleep And there are developmental concerns in our children with severe atopic dermatitis. There have been some recent studies that have come out that show how children with moderate to severe atopic dermatitis have trouble focusing in school, don't perform as well academically. And so I think the consequences of itch are potentially profound. And then, of course, there's a psychosocial impact of, just having a rash that's visible to everybody. And then another complication that we see commonly is infection, usually bacterial superinfection, and it's typically mild in the form of an infection we call impetigo, which is a very superficial infection involving mostly the epidermis, the top layer. But less commonly, the infection can be deeper, and I've certainly had some patients where bacteria have entered the bloodstream, leading to bacteremia, and I've even had a few patients who suffered from a complication of bacteremia called endocarditis, where they developed essentially infection on the heart valves. So when severe, the infectious complications can be significant. And in young babies, we see another type of superinfection with viral superinfection, most commonly of the herpes simplex virus. And this usually necessitates a hospital admission for IV antiviral therapy.
By superinfection, you mean that it's not like a super-duper infection. Why don't you explain what it is?
Yeah, so superinfection means that the initial rash or lesion is still the eczema, but then that becomes infected, so superimposed, And the reason for that is that we know that in atopic dermatitis, our skin makes certain proteins that almost acts like an antibiotic, and those proteins are downregulated. They're decreased in the rash of atopic dermatitis, and so we think that's why we see more infections compared to normal skin.
And those other infections that you were talking about where the bacteria gets into the bloodstream, that, I guess, is an example of the failure of the normal barrier function that we were talking about before.
Exactly.
Okay, so you convinced me this is worse than just an itchy rash, and you convinced me that itching is pretty bad. So what sort of treatment options exist for this?
So, it depends. I think it depends on severity, but no matter what the severity is, there are some good principles for gentle skincare that I counsel all my patients on. So in general, I advise all my patients to avoid fragrance. Because fragrance is a common allergen that can elicit a superimposed contact dermatitis, a skin allergy, another type of eczema. So I advise all my patients to avoid fragrance and any other potential irritating ingredients when it comes to their soaps, even detergents, moisturizers. And then I generally recommend all my patients to moisturize on a daily basis, ideally with something a little thicker, such as a cream or an ointment. And that's really just to maintain the barrier, because we know that atopic dermatitis is a disease of this dysfunctional skin barrier.
Before you go on, I have a question about the moisturizer.
Mm-hmm.
Just sort of over the counter, go to the drugstore, get a moisturizer, or are you talking about something more elaborate than that?
No, honestly, the over-the-counter ones are some of the best ones. The big brands that are fragrance-free, no frills, nothing fancy. You can find them in most drugstores. I don't know if I'm allowed to mention.
You can give it a plug, sure.
Yeah, I mean, so plain old Vaseline for somebody with severe atopic dermatitis. I just recommend plain petroleum jelly. Okay. That can sometimes be a little too greasy and icky for some people. So then I recommend a cream. So brands like Eucerin, CeraVe, Cetaphil, these are tried and trusted brands that don't put a lot of extra stuff into their products and tend not to cause allergic reactions or contact dermatitis.
Okay.
So getting in a habit of using a moisturizer like that every day and avoiding fragrance in all of their products, including soaps and even detergents, can go a really long way. But usually if the skin is inflamed, it takes more than that. And that's when we use topical steroids, which work excellent to calm the inflammation down and can be used safely and effectively when used for short periods of time. I have a lot of patients who are hesitant to use topical steroids, and I spend a lot of my time counseling on the safety of topical steroids, even strong ones, as long as they're not used on a daily basis for prolonged periods. It's only when you use them for a prolonged period of time that you run into side effects such as thinning of the skin and discoloration.
And what about the absorption of the steroids? I know a lot of people are familiar with a long list of side effects that you get if you take steroids in pill form.
Right.
Do the steroids get into your system if you just put it on the skin?
It is very difficult to have systemic absorption of steroids. You'd have to use a high-potency topical steroid head to toe, bathe in it for weeks to months.
Okay. So that's not really a thing then.
Yeah, it's not. It's very difficult. And if there's, in a patient with a lot of skin breakdown or open erosions or ulcers, then maybe it's possible. But even then, it's a minimal amount. So that is really not a concern. The side effects we worry more about are thinning of the skin and discoloration. But like I said, that really only happens if it's used consecutively on a daily basis, months to years, really.
And how effective is that at controlling the dermatitis?
So it can be quite effective, even in very severe cases, but we often recommend something called wet wrap therapy, where we have our patients put the ointment on and then sort of put like a wet pair of cotton pajamas on and then a dry pair, which works, but that's just not feasible for a lot of people.
That sounds pretty elaborate, yes.
Yeah, it is, and then it works to get somebody through a flare, but the reality is that it's not sustainable nor safe to use topical steroids every day for a long period of time. And for those more severe cases, we often resort to alternate therapies. One therapy I love is phototherapy, which is very safe, but also not always practical because it requires our patients to come into our office 2 to 3 times a week for many months. And so that just doesn't always work out with people's schedules.
That's a specialized kind of light
that's a very, yes. To? Yes, it's a very narrow band of ultraviolet B light. So when patients get exposed to this very narrow band of light, it is safe. And so we don't see the same risk of skin cancer that we see with just natural sunlight.
So it's not like a tanning bed.
It is not like a tanning booth at all.
Okay.
Yeah. Okay. No increased risk of melanoma or non-melanoma skin cancers.
So moisturizer, topical steroids, light therapy. Are there systemic therapies?
Yeah, we're very fortunate to have a systemic therapy called dupilumab, which is an interleukin-4 receptor blocker. It's relatively new over the last decade, but it truly has been a game changer because for a few reasons. One is it's very effective for most cases of atopic dermatitis, and it works quite quickly. But perhaps more importantly, I consider it to be one of the safest systemic medications that I have in my arsenal. We don't even check blood work for dupilumab. We give it to patients as young as 6 years old, and soon, in the next few weeks, we'll be learning that it will be approved for patients as young as 6 months old. And that's why I love using it, because I feel very comfortable. We have other systemic agents too, but I don't find them to be as effective, and most of them are immunosuppressive with a less favorable side effect profile.
You know, you've mentioned treating kids a number of times. Is this the kind of thing that children kind of outgrow, as we sometimes hear, like with asthma, or is this, if you've got it as a kid, you're going to have it as an adult and get used to it?
So a lot of parents ask me that question, and it's always hard to predict. One thing that I really focus on, especially during the initial visit, is the way I counsel is I try to explain that atopic dermatitis is a chronic condition. So it's not something that we really cure, but really something that we manage. It has its good days and its bad days, and we try our best to sort of anticipate and manage flares to the best of our ability. But with that being said, most children will grow out of it or have a milder form in adulthood. It's really the children with more severe eczema where sometimes it can persist.
The other thing I wanted to pick up on that you mentioned before was differentiating atopic dermatitis from contact dermatitis. Could you just say a little bit more about what contact dermatitis is and how you would differentiate those?
So contact dermatitis is another type of eczema, So if I were to biopsy contact dermatitis, I wouldn't be able to tell that it's contact dermatitis versus atopic dermatitis under the microscope. So the clinical presentation is very helpful. And what contact dermatitis is it's an allergic response. What we call we call it in medicine a type 4 hypersensitivity response. It's a delayed allergic response to something that physically comes into contact with the skin. So it's different than food allergy or seasonal allergies. The classic example of contact dermatitis is the rash you get from poison ivy, which is essentially a very acute eczema rash that has a lot of clinical signs that are a big hint for contact dermatitis. For example, we often see like the eczema papules or bumps in a linear configuration, almost in the shape of a straight line, where you can just imagine the leaf of a poison ivy plant brushing against the skin. And so the shape of the eczema plaques, often if it's in a very specific shape, like for example EKG pads, we'll see like circles of eczema that come from the EKG adhesives in the hospital. So that can be a big clue for contact dermatitis. But another thing that I haven't really discussed much is it's very unusual for an adult to all of a sudden present with atopic dermatitis. It happens, but it's rare. But when an adult all of a sudden develops this atopic dermatitis-like rash, you really have to ask yourself, is this something else? And in particular, contact dermatitis. It's difficult for the patient to really distinguish whether it's atopic dermatitis or contact dermatitis. Sometimes it can be really obvious. For example, a bracelet or a necklace giving a rash, that's often due to a nickel allergy, because most types of metal jewelry or costume jewelry have some form of nickel in them. But otherwise, it helps to come see your dermatologist, where we can try and get a really good history of what you're coming into contact with and try and determine if there's a possible contact dermatitis at play. And we also have a test we call patch testing, where we tape 80 different allergens onto our patients' backs, and we say they can't get their back wet for 5 days. It's a hardcore
That
test.
sounds miserable. Yeah.
It is. But it's worth it, because in the end we check to see if there are any allergens that are commonly contained in most common like household products, personal hygiene products, and we can see if our patients react to any of those, and then moving forward provide guidance on what types of products to avoid.
In general, are there guidelines that you can share with our listeners about what kinds of products to avoid if people have a rash and they're concerned that it might be from something they've come in contact with?
Probably the most important rule is to avoid fragrance. So if any product has a scent at all, it should be avoided. But the tricky part is even some unscented products have fragrance as a masking fragrance. So it always helps to look at the list of ingredients to see if there's any fragrance mix, or sometimes it's written as perfume. Sometimes it's written as balsam of Peru. So it can get tricky because there are many different synonyms for all these allergens. So that's probably the most important rule. Another common culprit for contact dermatitis is Neosporin. When a patient tells me it was voted as the allergen of the year, I think about 5 years ago, but we see that a lot. So
I went through tubs of that when I was a kid.
I know, and that's one of my my nerdy phrases is it's never too late to develop a contact dermatitis, which is very true. So even if you've been using it for years, it's just such a common cause of contact dermatitis. A good rule of thumb is keeping it simple. So unfortunately, a lot of natural products or products that are marketed as being natural or even organic, they have a lot of things that are found in nature that can cause contact dermatitis, certain oils and fragrances. So the big brands in the drugstores that I had previously mentioned are pretty good at kind of not trying to be too fancy and not adding too many preservatives or additives that might elicit an allergic response.
And any thoughts about what kind of soap to use or avoid?
So I always recommend Dove unscented soap because it's fragrance-free, but it also provides a little bit more of a moisturizing component compared to most other cleansers. But other brands like Cetaphil and CeraVe and Aveeno and Eucerin, they have pretty good fragrance-free cleansers as well.
Great. Any final thoughts about atopic dermatitis and eczema?
No, I would just that it's extremely common, and those general principles of gentle skincare really do go a long way. And we're very fortunate now to have the systemic agent dupilumab, which we didn't have 10 years ago, to help treat more severe cases of atopic dermatitis, and more research is underway. So although it's incredibly common and often debilitating, as I mentioned before, there's light at the end of the tunnel.
Well, that's great. Well, thank you so much.
Yes, of course. Thank you for having me.
My guest has been Dr. Sheila Shaigany. Dr. Shaigany is an assistant professor of dermatology at the Zucker School of Medicine and the co-director of the Inpatient Dermatology Consultation Service at Northwell Health. For more information about this program and to find past episodes, please visit medicine.hofstra.edu/wellsaid. You can also subscribe to our free podcast wherever you get your podcasts. Our listeners are welcome to send comments, suggestions, and questions to wellsaid@hofstra.edu. Until next time, I'm Dr. Ira Nash, and that's Well Said.